Swansea Bay University Health Board, who is the GP for us within the Macmillan Primary Care Cancer Framework Programme. So Gemma's kindly offered to present for us Module 2 today. Enjoy the session, everyone, and over to you, Gemma. Thank you very much, diolch.
Fab. So hi, as Sue said, I'm Gemma Eccles. I'm the Macmillan Lead GP in Swansea Bay. Please keep all questions to the end. And if anyone's having trouble seeing or hearing me, please let me know or mention it in the chat and Sue can pick it up. Can you all see the presentation?
Yes, we can.
Perfect. Okay, so we're covering the biology of cancer today. So I'll jump straight in. So the definition of cancer. Cancer is when your normal body cells change from their normal, controlled, regulated division process into one where the cells divide in an uncontrolled way and have the potential to spread to other parts of the body to form metastases. So this is your normal body cell. I'm sure you could have all drawn this very nicely when you were 11 or 12 and might be a bit more rusty these days. So you can see it's a nice normal looking cell with a nice normal looking nucleus. And the nucleus, as we know, contains all the genetic material and also contains all the instructions for how cells divide. So this is a diagram of normal cell division. So in normal cell division, everything inside the nucleus duplicates and then splits into two. So you end up with two exact same looking cells. In uncontrolled cell growth, mutations happen during the cell division. And that means that when the cells divide, they don't produce two perfectly identical cells that are the same as the cell they came from. Something goes wrong in that copying process that means that the cell that is produced is not exactly as it was before. And some things that can happen when that happens is that the cell doesn't understand what it's supposed to be doing. It misunderstands its instructions. It can start to continue to multiply out of control. So it doesn't just make two, perfectly normal cells. It might continue to divide and divide and divide despite signals telling it not to. If something goes wrong in the cell, there are normally procedures in place that keep things under control. If something goes wrong, the cell has instructions inside it of what to do if something hasn't quite gone right and how to repair itself. In these cells, that doesn't happen. It ignores those signals and continues to divide despite the fact something's gone wrong. And instructions that tell a cell that's abnormal to die, to stop it dividing in an uncontrolled way, doesn't happen again, and the cell doesn't die when it should. And if all of this happens, it can lead to cancer. So you can see here a diagram of some nice normal cells. Those are the purple ones in the picture. They all look identical. They're the same shape. They're the same size. They all look exactly like the cell that they've come from. And you can see the difference with the cancer cells in the middle. They're all different sizes. The nuclei look a bit strange. They're not quite perfectly normal. And even the untrained eye could look at this picture and say there's something not quite right with those middle cells. And this diagram here really shows how you can go from normal dividing cells to an invasive cancer. So you start off with the cell on the left here. That's a cell that's about to undergo a division. But you can see that cell looks slightly different to the ones around it. That cell has got a mutation in it. Something has gone wrong during the copying of the genetic material when that cell was dividing last time, and there is something in that cell now that's not quite right. So when that cell divides, you may end up with a situation called hyperplasia. Plasia just means growth, and hyper means too much. So it's too much growth. The cell's dividing too much. Instead of stopping itself when it's at one nice little line of cells, that has gone on to divide and produce what you can see there is a little lump of cells, a little clump. And if that process continues, you can end up with what's called dysplasia. So plasia, again, growth. Dys means there's something wrong. The cells aren't quite right. If you look at that second one along, you can see that the cells are broadly similar. They're not all different shapes and sizes. Once you get to dysplasia, the cells are starting to look a little bit different. They're not like the cell they came from. Something is not quite right with that group of cells. At this stage, the body can still do things to sort that out. This process here is still reversible sometimes, but if it carries on unchecked, what you end up with is the next stage along there, the carcinoma in situ or the cancer in situ. So that in that situation, the cells are dividing in a completely unregulated, uncontrolled manner. They all look different. They don't look like the cell they've come from. They're all different shapes and sizes. They're growing and dividing and growing and dividing with nothing checking them. But with an in situ cancer, they haven't spread anywhere else yet. They're still where they started off. The next stage is the one we all, look out for in this job, which is the invasive cancer. So what's happened there is the same as the in situ cancer. The cells are dividing. They're changing as they go. They're getting all different shapes and sizes. They're not like the cell they came from now. It's a big ball of different cells. And that big ball has started to divide and go through into the tissue surrounding it. It's invading what's surrounding it, and that's why we call it an invasive cancer. And as you can see in this picture here, it's invading the blood vessel there that's underlying that surface, and that means it will spread through that blood vessel to other parts of the body. So we've touched a little bit on this, but this slide just sort of goes through the difference between a normal cell and a cancer cell. So normal cells, always dividing, every cell in our body is probably continuing to divide and grow. There are obvious examples of this, things like your hair, your nails, your skin. These are all obviously turning over quite quickly, and we can see the result of the cell division and growth there. But even things like our bones and our muscles are continually remodeling themselves and growing and changing and repairing. And we need all this cell division in our normal cells to continue to grow and, heal ourselves when we get injured and change in response to exercise and all the things that we're doing day to day. But that process is really tightly regulated in normal cells. They have something called programmed cell death, which I touched on earlier. If something goes wrong in that cell division process, there's a genetic code in there that tells that cell something's not right with you, you need to go. And in a normal cell, that's what would happen. They also respond to external growth and anti-growth signals, so hormones and signals that travel through the body and tell that cell when to grow and when to not grow. There's a balance as well between the blood vessel development and the cell need. So as a tissue gets bigger, perhaps you've been to the gym, your muscles are getting bigger, then your body will be told, we need more blood vessels near this new big muscle. So you'll make new blood vessels to supply those new increased cells. But that increase in cell size never invades the surrounding tissue. That should never happen with a normal cell. In cancer cells, something has gone wrong. They're dividing, but nothing is regulating that cell division process. There's no mechanism for cell death. So even if the cell recognizes something's not right, it can't kill itself. They generate their own growth signals, so they don't need something from outside telling it to keep growing and keep growing. They develop their own growth signals and they keep growing and growing in response to those. And even if your body is telling that bit of tissue to stop growing, something's not quite right, the cancer cells cannot respond to that. They also have new blood vessel growth around them. They're telling the surrounding tissues to grow new blood vessels, but they do that in a quick and disordered way. That means that you often end up with lots of new blood vessels, and the blood vessel growth doesn't match the tissue growth, so you get little bits of the tumour that doesn't have a very good blood supply and might get a bit of necrosis there or cell death. And equally, you get lots and lots of blood supply around other bits where it's not perhaps needed in a normal tissue. And the last stage is tissue invasion. So the cells are not content with growing in a small tumour clump by themselves, but they start to move out into the surrounding tissues. And once they get into the bloodstream, that's when they can metastasize and spread. So the place that a cancer starts in the body is known as the primary cancer site, or the site of the primary cancer. If cells spread to another part of the body and then start growing there, that site is called a secondary cancer or a metastasis. And some cancers can spread to more than one area of the body, and you can get multiple metastases. So how does cancer spread to other areas of the body? Well, we saw in one of the first slides that when cancers start to grow, they can invade deeper into tissues. And if they invade into a blood vessel, then little cancer cells break off and become part of that blood supply. And as they're traveling through the bloodstream, they can seed off into other places. And you can see in this picture how that happens, because there are gaps in the blood vessel capillaries that cancer cells can sneak through and start to grow in a new place. There's also the lymphatic system, which is part of your immune system. And it's a bit like the system of blood vessels in that there's a sort of pipe system network that goes through the body, and cancer cells can travel through that as well and start to grow into new tumours. Here's a nice diagram of the lymphatic system. A lot of us are not that aware of it. It involves all of our lymph nodes, our tonsils, the spleen, and lots of vessels as well that travel through the body. And you can see in this picture, in exactly the same way that the cancer cells invade blood capillaries, they can invade lymphatic capillaries and spread around to the lymph nodes. So different cancers can sometimes spread in different patterns. Breast cancer commonly spreads to bones, lung and liver, and sometimes they spread quickly to what's nearby, and sometimes it's more that that particular cancer is very good at invading blood vessels and travelling around the body. Prostate cancer often spreads to bone, bowel cancer often spreads to liver, and lung cancer will often spread to brain and bone. Now, those aren't the only places those cancers can spread, and they don't spread to those places in everyone who has them, but that's a pattern of spread for each of those, and it probably, as I said, relates to what's nearby as well as how good they are at invading blood vessels and lymphatics and surrounding tissues. So what's the difference between benign and malignant growth? Benign tumours. So what happens in a benign tumour is that there's something not quite right with cell growth. The cells are dividing and nothing's stopping them from dividing. But those cells are still normal body cells. They're perfectly recognizable as what they started out as. They're just growing when they shouldn't be growing. The benign tumours often have what's called a capsule around them. So that's something that's containing them and stopping them from spreading out anywhere else. And they grow by expanding around themselves rather than spreading from place to place. They normally grow very slowly as well, and they're still under some cell control. They haven't gone completely haywire as cancer cells do. And they stay where they are, they remain localized. Now they can still cause trouble because as they grow bigger, they press on surrounding structures, and that can have its own difficulties, but they don't spread around the body. Now, cancer cells, tumours don't have capsules generally. They tend to invade whatever is nearby to them, and they grow in a variable way. Some will grow very quickly and some are more slow growing, and they don't listen to what the body's telling them to do. The control mechanisms that usually keep things in check don't work. And as we've said before, they do spread around the body by metastases. There are lots of different types of cancer. Cancer is one word for a process really rather than a disease. There are more than 200 different types, as it says here, and we group them largely by the type of tissue that they start in. So carcinomas usually start in sort of epithelial tissues. Sarcomas usually start in muscle, or osteosarcomas in bone. Leukemia are blood cancers. Lymphomas and myelomas start in the lymphatic system and the immune system of the body. Brain and spinal cord cancers are exactly as it says on the tin. They start in the brain and spinal cord. Carcinoma is by far the most common type of cancer, and about 85% of UK cancers will be carcinoma. So a summary here of cell growth. Cells change from their normal controlled to uncontrolled growth when a cancer develops. And cancer growth has the potential to spread to other parts of the body through the bloodstream or the lymphatic system. There are common patterns of spread for some cancers, although not all people will conform to those patterns of spread. And as we say, there are more than 200 different types of cancer, depending on which type of cell is the original cell that it originates from. And tumours can be benign or malignant, which a lot of people don't realise, although I'm sure with a professional audience that is something that you will know. So staging of cancers. Staging is something that can be really useful in terms of planning treatment, and also patients expect to know their stage now. They want to know whether they're what stage their cancer is. But it can, in some cancers you can have a quite advanced stage, but actually can be quite treatable and have a long life expectancy, whereas other people can have a very early stage cancer, and actually that doesn't tell you too much about what that person's prognosis will be. But we're all very used to hearing about cancer stage, so I'm just going to explain a little bit about where that comes from. So the system we use is called the TNM staging of cancer. T refers to the tumour, then the extent of the primary tumour. N is nodes, so lymph nodes that are affected, and M refers to metastases. So looking at T, this is split further in up to stage 4. So primary tumour can be 0, no evidence of primary tumour, carcinoma in situ, or 1, 2, 3, 4, depending on how big and what the local extent of that tumour is. So 4 would be usually a more advanced tumour than a 1. N, whether lymph nodes are involved or not. So that's a 0 or a 1, 2, 3, depending on how many lymph nodes are involved, and in some cancers that relates as well to where they are in the body related to the original tumour. M is metastases. You either have them or you don't. So it's either a 0 or a 1. And then there are gradings as well. And this is when histologists look at the cells and decide whether the cells are grade 1. So they still look similar to the cell they've come from, ranging through to grade 4, where the cells are undifferentiated. They've become very different to their original cells and they're very difficult to categorize. And in between, there are grades 2 and 3, where things are perhaps more one way or another. So cancer staging helps to decide what cancer treatment you might be eligible for. And there are lots of different types of cancer treatment now. And within each broad category, there are lots and lots of different types as well. So we're not going to cover every single thing today, but I'll try and broadly cover the principles of these different cancer treatments. So there's surgery, radiotherapy, chemotherapy, hormone treatment, biological or immunotherapy, stem cell and bone marrow transplants, and supportive therapies. Most of these you will have heard of, but some might be a bit more foggy than others. So surgery is probably the most straightforward, and I think if you've got a solid tumour there, one of the most straightforward ways of treating it is to cut it out. And 49% of those cured with cancer are treated with surgery. Those are people with a localized mass that can be easily removed or not easily removed, but can be removed from the body. And it's the best treatment for cancers that haven't spread because they're in one place, they're easy to get at and remove. So there's lots of different reasons why you might have surgery if you've got cancer. So there's prophylactic surgery, and people with a really high risk of things like breast cancer, they can opt to have elective removal of breast tissue so that they reduce their risk of ever getting breast cancer. You can have surgery to stage the disease. So you can have a small sample of tumour cells removed or the whole tumour to see what stage or grade that tumour is at. Some people have surgery to remove secondary tumours. So if you've developed a metastasis that's causing trouble in the lung or in the brain or somewhere where it can be removed, then you may have surgery to a metastasis to remove that. Sometimes surgery is palliative if a tumour mass is causing a lot of pressure and causing pain. People will operate on that to remove that tumour and relieve symptoms without the hope of curing the cancer, but purely to make that person feel better. And the other type of surgery that we see is reconstruction or rehabilitation surgery. And again, in breast cancer, that's a classic example. You may have a breast reconstruction following breast surgery to reconstruct your breast tissue and give a more normal appearance. So the implications of surgery. First, it's important to remember that surgery is risky and it's not for everyone. And it's got to be considered in light of the potential benefits of that surgery. So lots of people with cancer feel if they've got a tumour, they want it out, but that's not always the best treatment option for that person. And surgery can have its own effects as well. It leaves scars, physical and psychological, that can affect people's self-esteem. It can affect the way they're viewed by society. It can change your body image, especially things like stoma procedures that leave you with visible change. Can affect relationships. It can change your lifestyle. You can be left with disability that leaves you with mobility issues or functional issues and even employment issues. So there are big implications to having surgery, and it's something that needs to be taken on knowing all the risks and benefits. So moving on, radiotherapy. Radiotherapy is using high energy X-rays and similar type of beams to cause damage to cells, which makes it difficult for them to replicate. So most of the treatment types we're going to talk about now, the aim is to cause damage to cancer cells, and usually will cause damage to normal cells as well, but primarily targeting the cancer cells to try and treat the cancer. 40% of those cured of cancer are treated with radiotherapy, and it can also be used in a palliative way and as an adjunct to existing treatment. So, for example, if someone has got a big mass pressing on their mediastinum and causing difficulty with breathing, or venous constriction, then you can have palliative radiotherapy to reduce that mass and relieve symptoms. It's not always curative, and it can be used alongside things like chemotherapy and surgery as a sort of extra treatment to reduce the risk of recurrence or increase the risk of cure, increase the chance of cure, I should say. Two main types of radiotherapy. There's electrically produced X-rays from a filament or external beam radiotherapy, and there are also those produced through decay of naturally occurring or manufactured isotopes, so radioactive cobalt or internal beam radiotherapy. And external radiotherapy is low energy, so you get the maximum dose on the skin surface, and it's usually used for skin tumours. Or there's high energy with megavoltage equipment using a linear accelerator or a proton beam. This causes a deep penetration with minimum dose on the skin, so the beam is aiming deeper into the body, and it's used to treat tumours that are inside the internal organs. There's stereotactic radiosurgery or gamma knife. So stereotactic means mapping out exactly where you want that beam to go in a very clever way, and targeting a deep tumour from various different angles, trying as much as possible to spare the surrounding tissue from the radiotherapy. And that's often used for things like brain tumours, where you really don't want to damage the surrounding tissue because the effects can be quite extreme, but you really want to get a high dose of radiotherapy into that tumour. And radiotherapy can also be used during surgery, giving just a high dose, quick target to that area, again, trying to spare the surrounding tissue. So internal radiotherapy can be systemic, where you're given intravenous radiotherapy, for example. That's used quite commonly in thyroid cancer, where you give radioactive iodine, which travels through the body and specifically targets the thyroid gland and treats that, and strontium-19 as well for bone pain. There's intracavitary or intraluminal internal radiotherapy, where a radioactive source is placed in a cavity within an affected organ or in a hollow organ like the esophagus, and that's sometimes used for gynae cancers. There's also interstitial or brachytherapy, where a source of radiotherapy is placed directly within the tumour, and that's often used in things like prostate cancer. So they will put a source of radiotherapy within the prostate gland, and that sort of treats the gland from within, with the advantage then that you're not treating so much the surrounding tissues or the rest of the body. So side effects of radiotherapy. Because it damages the surrounding tissue, it can leave you with a feeling of fatigue. It can cause loss of appetite and weight loss, and it very much depends on which part of the body is targeted by the radiotherapy, which symptoms you'll get. Radiotherapy to the skin will leave burns. It leaves a sunburn-like burn that can take a little while to settle down, and that can be quite uncomfortable as well. Head and neck radiotherapy will inflame the lining of the mouth. It will cause dryness of the mouth, and you can even get ulcers in the mouth as well, so that can be quite difficult to deal with. Radiotherapy to the chest can give you heartburn-like symptoms as it irritates the lining of the esophagus and the stomach. In the upper abdomen, it can cause nausea and vomiting, again, as it damages the stomach lining. And in the lower abdomen, you get the effects of the lower organs there, so cramps, diarrhea, urinary problems, as the bladder and bowel get affected. Long-term side effects. Radiotherapy can permanently damage growing hair areas, so you can end up with hair loss in the area being treated. It affects the reproductive system, so that some people who have radiotherapy to their reproductive organs will end up with infertility. Radiotherapy also can cause longer-term damage to cells, which unfortunately in itself can affect the way those cells replicate in the future and divide. So that could in the longer term cause a secondary cancer, where that loss of normal cell division is caused by radiotherapy in the past. You can get skin damage, scarring, sensitivity to light, and that all sort of follows on from that sort of sunburn effect. And you can get also fibrosis that happens following radiotherapy, where the tissues harden. And that's a particular problem if you've had radiotherapy to the lungs, where you can end up with lung fibrosis and lung tissue that doesn't work as well as it should, and exchanging oxygen for CO2 doesn't work as efficiently as it would in non-scarred lungs, which can leave people quite breathless. So radiotherapy works because cancer tissues are targeted more than normal tissues, but any part of the body where the cells are dividing quickly will be affected by radiotherapy to that area. So normal tissue like bone marrow is often affected, as well as lymphoma, and there are some parts of the body that are not that sensitive to radiotherapy, like the bones, and so sarcoma of the bone is not usually susceptible to radiotherapy. So chemotherapy, this is using medication to treat cancer, so drugs. And the type of chemotherapy used to kill cancer cells is called cytotoxic chemotherapy. Cyto meaning cell and toxic meaning poisonous. So drugs that are poisonous to cells, and chemo just means a medicine. So 11% of those cured of cancer are treated by chemotherapy, although a lot more people who are not cured of cancer would also receive chemotherapy. There are lots of different ways of using chemotherapy. As I said, it can either be with the aim of cure, so you're giving chemotherapy and that is the main treatment that person is having that will sort their cancer out. It's also used as an adjunct to other treatments, so it can be given before another treatment. So you may have a course of chemotherapy to try and reduce the size of a tumour before you operate on it, for example. It can be used in the opposite way to that as well, after surgery, to reduce the risk of a cancer coming back. And chemotherapy can also be used in a palliative sense to try and reduce the size of a tumour and reduce the symptoms that go along with it, but without the aim of actually curing that cancer. So giving chemotherapy drugs, it can be a single drug that's given as chemotherapy, but more often it's a combination of a few different things that all work in different ways. And it's usually given as an infusion into the vein, and it's given intermittently. So you don't have all of your course of chemotherapy in one day, but you'll usually have cycles of chemotherapy, which we'll go into. So this explains why we have cycles of chemotherapy and gaps in between. You can see on this graph here, we have normal cells along the top and cancer cells along the bottom. So your body has more normal cells to start with than cancer cells, you'd hope. So this is where we start. And at the point the arrow is hitting the top of that line, that's where the high dose chemotherapy is given. And you can see that normal cells are affected by chemotherapy as well. Any cell in the body that's dividing will be harmed by chemotherapy. But the aim of chemotherapy is to affect the cancer cells more than the normal cells. So at the point you're giving the chemotherapy, normal cells and cancer cells both drop in number dramatically, and then they both have time to recover before the next cycle of chemotherapy. Normal cells will recover more than cancer cells in that time because they have genetic programming that tells them exactly how to grow, whereas if you remember, cancer cells are growing in a disordered way without any regulation, so they don't really know what they're doing and they're trying to get back on track, but then you hit them again with another cycle of chemotherapy, and hopefully in this stepwise way you keep knocking down the number of cancer cells more than you knock down the number of normal cells. You give some recovery time in between for the normal cells to get back up to a safe level, and over time you erode the number of cancer cells until eventually in curative chemotherapy you get rid of them altogether. So it can be given, as we said, directly into a vein or artery. Sometimes it's given intramuscularly or into an organ like the bladder. Can be given into the CSF, into the spinal fluid. You can receive chemotherapy topically in creams, and that's used sometimes in skin cancer and can also be taken by mouth. So there are lots of side effects of chemotherapy, as you can imagine, because it affects usually the whole body and it affects any cell that's growing. So immediately after you've had chemotherapy, you might have soreness at the injection site. It can feel uncomfortable when you're receiving chemotherapy. Some people say it feels cold or itchy near the vein. Of course, there are always the possibility of allergic reactions, and that would usually happen immediately. And the other risk with any intravenous process is that the drug leaks into the tissue surrounding. Unfortunately, that's more harmful than with most things because the chemotherapy is designed to damage growing cells, so it can cause quite nasty wounds if that does happen, if you get extravasation of chemotherapy drugs. In the shorter term, a lot of people will have hair loss. That's because hair is a rapidly growing tissue and will be very much affected by chemotherapy. Again, blood cells are constantly dividing and renewing, so they're really affected by chemotherapy that targets dividing cells. So you'll often get a low blood count, nausea and vomiting, loss of appetite, sore mouth, feeling ill and fluey, tired, weak, getting all sorts of bowel symptoms, and urine can be affected as well. In the longer term, people can have long-term anemia. They can end up with skin reactions that leave them with long-term sensitivity. There can be damage. Some of these chemotherapy agents can cause, again, fibrosis to the heart, the lungs, the kidney. You can get damage to your nerves, so you can end up with tingling and numbness in fingers and toes. They can damage the nerves in the ear and cause hearing loss. Again, they can cause infertility and changes in the menstrual cycle. And again, because they target dividing cells and change the way they're dividing, you can end up with cancer related to that damage in the future. Bone marrow is really sensitive to chemotherapy because it's constantly dividing and making new cells. If it does get affected, then usually the thing we worry about is a low white cell count. So after someone's had chemotherapy, we know that some chemotherapy agents really do cause a drop in your white cell count. And the thing we especially worry about is a drop in the neutrophil count leading to neutropenia. Low neutrophil count is bad because we need our neutrophils to fight infection. And if we have a low neutrophil count and we get an infection, you can get really, really unwell. Low platelet count, again, platelets are important for blood clotting. So if we drop our platelets, then any injury could lead to a potentially devastating bleed. And of course, low red blood cell count will lead to anemia with lots of symptoms there as well. So other cancer treatments, and these are what people tend to know a little bit less about because they're relatively newer than surgery and chemotherapy and radiotherapy, which are the sort of traditional line. So biological treatments, these use natural substances from the body or drugs made from those natural substances to stimulate the body to attack or control the growth of cancer cells. So they're very clever in that they use the body's own immune system to target the cancer cells. And there are different types of biological treatments. There are things we use alongside chemotherapy, like the colony stimulating factors that help you to replace your blood count when you drop it due to chemotherapy. There are cancer growth blockers, which reduce the effect of the cancer growth factors in dividing cells, and they can also stop the cancer from producing new blood vessels. So that's what anti-angiogenesis means, angio meaning the blood vessel system. Immunotherapies, including monoclonal antibodies. So these are targeted treatments that tackle a specific type of cell. So much nicer to use than the chemotherapy that attacks every cell in the body without really thinking about it. These are targeted treatments that just try to target the cancer cells. And there's also gene therapies, and these are emerging all the time where genes are inserted into the cells that are growing to make the cell die or grow more slowly. So you can imagine in those original slides we saw where the cells are growing out of control, if you could just put something into that cell to turn that system off and say, you know, stop growing now, or something's not quite right, this cell needs to die, then that could prevent the development of cancer further on and also reverse cancers that have started. So immunotherapy, as I said, is relatively new, and it's one type of biological, and it works to harness the substances produced by the body's immune system to fight cancer. And the immune system is great, and if we can use the potential within your own body to help fight a cancer, then that's always going to offer longer term protection from that disease and fewer side effects because you're being very specific in what you're targeting. Hormone therapies, these are especially good for cancers that are very responsive to hormones. Some types of breast cancer especially are very hormone responsive and will grow in response to estrogen, for example. So we're using hormone treatments to stop cancers from growing in response to hormones and also to switch off growth in other cancers. They use the sex hormones produced by our bodies or drugs that block them to treat cancers. Unfortunately, not all cancers respond to hormone therapy. They need to be hormone sensitive or hormone dependent. And there are various different types of cancer that do respond to hormone therapy. and these include breast, prostate, womb, ovarian and kidney. Other therapies, stem cell and bone marrow transplants and supportive therapies. So stem cell and bone marrow transplants, what happens with a bone marrow transplant is that a very high dose of chemotherapy is given within the bone marrow of the person with cancer to take away all the cancer cells in that area. And then someone else's bone marrow that's been matched is put into that cavity and replicates and gives you a healthy bone marrow system. But it's very grueling treatment to go through, as you have to have very, very high dose chemotherapy in the first place, and then get through the bone marrow transplant as well. And there are other supportive therapies that people have while they're having cancer in order to help them get through the other treatments usually. So treatment pathway, people can have single treatment, they often have multiple treatments. People will often have surgery, chemotherapy, radiotherapy, sometimes all three. Sometimes they'll have a hormone or biological treatment on top, and they will be followed up. Some people will be cured by their first course of treatment and not need anything further. Some people will be put into what's called remission, where the cancer is not actively dividing and there's no sign of cancer, but there's not a guarantee it won't come back. And sometimes, the cancer doesn't respond to an initial treatment and a second line treatment is needed. So the primary care EUCONS tool helps professionals to assess toxicity of treatment. So for people who are on cancer treatment, the EUCONS tool helps you to go through and assess the patient from the point of view of side effects. So the background to this is that systemic anti-cancer treatments have a risk of significant and potentially life-threatening toxicities. Even when you finished your course of chemotherapy, you can still be at risk of having toxic side effects for 6 to 8 weeks after. And with immunotherapy, the side effects are even longer, at least 12 months and sometimes longer than that. So the EUCONS tool has been designed to help us as doctors and nurses to pick up when a side effect or symptom might be related to a treatment that's been had. Everyone who's undergone systemic anti-cancer treatment will be given an alert card and advice lines with a 24-hour helpline to call. And all services are guided by the EUCONS triage tool, which is a series of questions that you can go through with a person to assess the risk that their symptoms are due to their treatment. So it's standardised practice across the UK. As it says here, it gives you a framework for triage and assessment. And it was initially developed for hospital helplines, but actually it's really helpful in primary care as well in managing anyone who is undergoing oncology treatment. So people will often, even though they're given a helpline number for secondary care or for their treating team, they will prefer to contact their own GP because they often have a relationship with the GP or practice nurse and feel like they're more comfortable contacting that person. People often lose little bits of card and paper as well, so they might forget that they were given a 24-hour contact number. And they also sometimes think, well, it's just a bit of diarrhea, I don't want to bother my cancer team with that, I'll just chat to the GP. But the EUCONS tool can help us to, think about whether these symptoms might be more significant than the person initially thinks, and to identify people who might be at risk of being seriously unwell. And it uses a traffic light system. So you ask a few questions, for example, about nausea. How many days have you had it? What are they managing to eat and drink? Are they taking any antiemetics already? Are they passing urine? Are they constipated? Do they have diarrhea? And then you grade them according to this sort of traffic light system. And the traffic light then will give you an outcome of what you need to do. So most people will probably be able to be managed at home. And as long as they're eating well, drinking well, passing urine, not had the symptoms for long, then in a lot of cases you can manage that as you would anyone else. But for some people, you'll need to discuss them with a helpline, and some, even where you may not have suspected that person was as unwell as they were, a certain combination of symptoms in someone who's had anti-cancer treatment are much more worrying and would need a 999 assessment. So this is the triage process. So you be called up presumably by someone who's unwell after their chemotherapy, for example. So the first thing you want to do is work out whether this is an acute emergency. Are they short of breath? Are they having a heart attack? Is this a life-threatening moment where you just need to abandon and call 999? But we're all probably quite familiar and confident with doing that. The next thing is to check through what treatment that person has had, when did they have it, do they have any other medical problems that might be significant, are they on any other medication that might have implications for their symptoms as well, you know, are they diabetic, are they at higher risk of becoming dehydrated, and then you establish what is their key worry and you grade this first. And because if that is red and tells you to call 999, you don't need to go through the rest of the assessment. And you move through that checklist then to grade all the toxicities and look to see what advice you need to give. And it gives you something you can document then as something that you've done. So key points, telephone assessment. Probably when this was thought of, this was quite a unique thing, but we're all assessing most people by phone these days, aren't we? So it's the ideal is to speak to the patient wherever you can. And I know that's not always possible, but even having them in the room while you're talking to someone else, you can hear their responses is useful. And it always helps you to assess how unwell someone is, doesn't it? If you've actually spoken directly to them, you get a feel for how ill they are. Do they have an alert card? Do they need to ring the number that's on the alert card rather than you? Is there something you should be aware of that perhaps you don't know about? Think about sepsis, especially in people who've had chemotherapy and might have a low neutrophil count, as we mentioned before. Anyone with a fever who's had chemotherapy and you don't know what their neutrophil count is, you need to assume that it could be sepsis. And that they might not have their usual immune system in place to deal with that. Like all guidelines, this doesn't replace your judgment. And if you think someone's really unwell and needs to be seen, then you can override the advice on the card, and you can contact the helpline, and ideally do that when the person is still with you. Although at the moment, again, we're usually on the phone, so it may not be possible to do that while they are with you. So here are the key tips. Could this be sepsis, or cord compression is the other emergency we'll worry about with people with cancer? Ask, have they got an alert card? Do you need to get specialist advice? Is it something you don't know much about, like immunotherapy? Contact a 24-hour helpline for advice. Ensure diabetes is closely monitored, and think about the risk of thrombosis as well. These people aren't moving around much. Their medications will put them at higher risk. That's something we are always thinking about it as GPs, but just as a reminder there, think about, could it be thrombosis? And that, I think, is the entire talk. I hope you've managed to bear with me. It's quite a lot of talking there and not much interaction. Do feel free to ask anything, although I can't promise I'll know the answer.
Gemma, can I just say a big thank you? You've literally come in 12:59. Very impressive. Thank you very much. And there was a whirlwind of information there, so
it's a lot of information.
Yeah, huge amount from the beginning to the end. So thank you very much for that. I'm just looking at, there's no questions come in. Hang on, let me just check. Someone's just saying, oh, it takes ages to. Thank you, Gemma. Just to say thank you to you. I can't see any questions at the moment, but I just want to remind everyone before they leave us is the fact next week is module 3. And it's all about how to do cancer care reviews, how-to guide. And it's Juliet Norwood, the regional nurse for South East Wales, who is also a practice nurse in Cardiff, will be doing that module and sharing with you tools and resources. So I hope you all can join us next week, same time, 12:15. In the meantime, if there are any questions, perhaps you could email us and we can respond to you by email if need be. We will, as mentioned, we've recorded this today so we can share this recording with you further, and we will also send you the hyperlink for the Primary Care UCONS tool as well.
Yeah, so I think that's worth having a look at yourselves really, and have a look